Well, welcome. Tonight we have a very special guest. I'm not quite sure how to characterize him because you seem to be in a unique position here. So let's start with an introduction.
Well, first of all, thank you for the invitation, and I really appreciate the opportunity to come and talk about ophthalmology in Milford. It's been a pleasure of mine to be here tonight, and I'm looking forward to it very much. Glenn Goodman is my name. Been in the area here for 31 years practicing ophthalmology.
Now, you're located up the top of West Street, basically by the courthouse.
Yes, yeah.
Can't miss the sign.
Can't miss the sign. No, that was a suggestion years ago when I bought the building to have a nice presence up there. It's a beautiful location, and some of the sign companies in Milford were happy to have my business.
Now, help me understand, because you're not a hospital, but you have operating rooms. You know, you're not ye old ophthalmic surgeon, you know, from old days with a little office and one chair. How would you describe your practice? Because it is unique.
Well, thank you. It is unique. We have a very state-of-the-art center there. A lot of hard work went into it. And we have basically two different portions of ophthalmology being practiced there. When I'm not in the operating room, I'm doing medical eye exams and diagnosing, treating various conditions in young people, old people, and from run-of-the-mill red eye, pink eye, conjunctivitis type of infections to serious glaucoma and blinding disorders. And that can be done in any building that's appropriately designed. There are no special permits per se to do ophthalmology, as there wouldn't be with any specialty, gastroenterology.
But yet, didn't you have to get a special license for your
Well,
practice?
yes, that's the other side of the building. That's the crown jewel in the building there. That's the cataract surgery center, a portion of the building. That is a very specialized facility that took 2 years to develop because of the state and the federal requirements. It's essentially to the state and the federal evaluators and the licensors, it's a hospital. And whether it's Milford Hospital or the Cataract Surgery Center, or for that matter, Mass Eye and Ear, we all have to play by the same rules regarding sterility and every aspect from the time the patient walks onto the property to the time they get signed in, to the time they have their operation and get signed out. There are regulations literally by the book, and it's a lot of constant monitoring.
So you're held to the same standard and regs as Uncle Frank down the street, Frank Saber's medical center. Absolutely,
yes. The accrediting organizations are largely the same, and the sanctions are no different. The state and or the federal regulators, appropriately so, and I agree with all of this, can shut any of these centers down, whether it be a hospital or my center, if we are not following the rules. Yes.
So like a JCO type standard that the hospital has to live to, they're not going to cut you any slack just because you're not a huge medical center.
No, not one bit. The minimum requirement, just as it is in a hospital, is every 3 years you have to have a 2-day on-site inspection by Medicare, and it's a very intensive process. They actually, it's the several I've had, because I've had 3 of these now. I should add that we've passed them all with flying colors on the first try each time.
Hats off to Mother Rachel for the admin.
Yeah, exactly. And it's typically 1 or 2 nurses who specialize in outpatient surgical facilities, and oftentimes a physician. These are professionals who are retired or semi-retired and who don't get paid. They do this to ensure that the surgical facilities around the country meet minimum acceptable standards. and they go through all of our books, all of our regulations. They observe me in surgery. They pull patients aside, apart from me being in the room, to ask how the experience was for them. And it's very rigorous. And then what happened the last time we had this, a year or so ago, 2 years ago in December, as a follow-up, the state investigators came through. Again, just part of their doing their job. And this is another whole group of, in this case, 2 very experienced nurses who made sure that the facility was up to par. And if I say so myself, we've never had any detriments, and the investigators that come to do these inspections have always had fairly glowing reviews of our efforts. And let me say at the outset, certainly it's not only myself there. There's a whole team behind me that's responsible for any number of things, from sterility to planning, office planning, to patient care. I could talk on and on, but we have to.
So now these inspectors, like when
yes,
when I was running the diagnostic lab, College of American Pathologists was our accrediting agency, and they sent in laboratory directors. So these were people who really had run clinical labs. They knew what to look for. So it wasn't like you could get a young inspector and they'd overlook something. It sounds like about the same idea.
That is exactly correct. One of the issues, just to highlight that, is we use, it's obviously with eye surgery, there's a lot of cutting of tissue, and there was a tendency around the country 5 years ago for surgeons and facilities to purchase what are called single-use blades, single-use instruments, and re-sterilize them and reuse them, thinking, quote, nobody would notice. And for example, when these inspectors come, they want to see how many surgeries I do in a course of a year, and they want to see invoices for that number of disposable blades. And so there's no cutting corners.
So they were using disposable scalpels and autoclaving them?
Yes.
Now that's a scary movie.
Absolutely.
I mean, when you think about it, as any device manufacturer I've worked with, you validate for use. So there's no way I'm going to put into a disposable what I put into a reusable, because I only expect it to be used once.
Well, you understand that, and the truth of the matter is the physicians and the staff understand it, but like anything else, there's always the tendency to save money and cut corners. And once you start, in my opinion, once you start down that route, you lead by example. And I lead by example, but we never would do something like that, yes.
Well, I mean, it'd be hard for a staff member, if they see the CEO essentially, you know, the chief medical officer of the group, cutting corners. I mean, it used to be the problem, like when we were in Moscow, and you'd see them reusing needles, and they, quote, autoclaved them. And you sit there and say, wait a minute, guys, you know, this is not a 17, a huge gauge needle.
Mm-hmm.
Autoclaving may kill a lot of the protein, but you're still going to have some of that DNA flitting around that can be picked up by retroviruses.
That's exactly, well, of course, yes.
And then if they see you doing it, well, maybe I don't have to clean, or autoclaving's kind of annoying. Maybe I can just rinse it. Like you said, it sounds like a horrible slope that you're going to slide
That's
down.
exactly right. And you said it very well. That's the slippery slope that you think nobody's going to see it. And the real risk there is patient care, because there could, as you say, be germs of any number of sorts that don't get removed, and they're now implanted in somebody's eye. Yeah.
Now, you set up a surgery suite and a traditional eye care suite. I don't know of very many in the area like that.
No, this was a dream of mine over the last a decade or so, and I have made as many mistakes as I've had successes. And when this building up at West Street and Highland Street was on the market, it was, as you may recall, if I say, a fairly dilapidated a daycare building, and I didn't see that. I saw a beautiful surgical center there, and a lot of people thought I needed a hit in the head with a baseball bat. But I stuck to my guns and, you know, emptied out the bank account many times, and and it's I have no regrets at the present time. So in 2008, when I was doing this, just coincidentally, I wish I could claim some innate business acumen here, but it was 99% my good fortune, i.e. luck, that the state of Massachusetts in 2008 changed the rules on surgical centers, not just in Milford and not just for ophthalmology. Statewide, you now cannot, basically you cannot set up a surgical center in any specialty in Massachusetts for the foreseeable future.
So you got in right under the wire.
Yes. In fact, I have in 2008, I received the last ophthalmology license for this type of endeavor. There was a hand center down on the Cape that they were the last ones altogether. So it's priceless that I was able to do this. And my feeling was, as I was planning the center, was to do it second to none. If I was going to do it, I wanted it to be what we call now, and this is a tribute to Rachel, concierge cataract care. We don't just do cataracts, and the emphasis is on concierge without the concierge cost. There's a new trend in medicine, concierge care, where you pay the doctor money to be a select patient. We don't do that. We just treat everybody in a very high-end, first-class way, to use an airline analogy, and that's coming directly from me and my motivations. That we make it look relatively easy, but there's a lot of hard work by very many good people behind the scenes that make the experience for the patients largely very satisfying for them, and therefore for me and the staff.
So I can get concierge level at economy price.
Yes, we only.
I would like that.
Yeah, well, I enjoy surgery and I enjoy the patient, so that's a good marriage for me, and even for those patients that don't have insurance, we don't schlep them to a hospital just so I just do the surgery don't get paid. That comes up, not looking for sympathy or a pat in the back. It's just my way of doing things. So several times a month, somebody will not have surgery that they can have it done in the center, but they get the same care, the same.
Now, fundamental question always comes up. I just moved to Milford. I need eye care. I can go, and I don't mean any slam, but I can go to Kmart, because you see a lot of ads that you can get the same level of care for a rock bottom price, $2, we'll do your cataracts,
Yeah.
I can go to an optometrist, I can go to an ophthalmic surgeon. Okay, I go to the phone book, and I see Goodman ad's big, but I see lots of ads. How does a new person, what would you recommend that they look at, evaluate to pick somebody who's going to provide? I guess cardiac care would be right up there too, but eye care is probably the one thing that hits you straight from morning till night.
Well, you phrase it in a very astute way. Having done this in private practice in Milford for over 30 years, I think I have a good perspective on how I could advise patients to approach those type of questions. And it typically, there's no right or wrong way to do it, and there's no way that always works without some trepidation. If it's a...
Wait a minute. First of all, let me interrupt.
Yes.
You've been here 3 decades. So this is not, what worries me
Yep.
and I shouldn't call it the Kmart, but the discount store, the big box store, whatever they're called, is I'm going to get somebody who comes in for 6 months and leave. So right away you're telling me, okay, you've been here 3 decades. So you're kind of invested in Milford. So there's a
Yes.
positive I like.
Yes, thank you, yes. Well,
Now
but
what?
Well, I think if it's a matter of anything that is a serious condition, and let's limit this to an ophthalmic or eye disease condition, just to give credit where it's due, many of the optometrists in the community are very good these days. The younger generation of optometrists are very well trained, and they're excellent at diagnostically coming to a decision, and then they refer usually to an ophthalmologist. So I've tried to have a good working relationship with the community's optometrists, because a lot of patients, because of their health plans or their their history of growing up. The family might have gone to an optometrist for eye care. Nothing wrong with that. And then the rubber hits the road, to sort of mix metaphors, about if it's a serious eye condition and the patient needs to be referred. That's where I can speak to what's important. So if it's, for example, the two big ones or three big ones would be glaucoma, macular degeneration, and cataracts. You want to go to an ophthalmic surgeon or ophthalmologist who you can trust. And I think that's something that you perhaps get from word of mouth. I think it's critically important that the patient feel comfortable with his or her doctor, that the doctor, the ophthalmologist, should be board certified. And what that means is a process by an independent organization, that the American Board of Ophthalmology, that grades us. We have to pass a written exam, then we have to pass an oral exam. That's at least the foundation of the training program. And the doctor should have some experience in the condition that you're coming with. So if I see somebody, hopefully, if I see somebody with a cataract, hopefully I can advise them intelligently. Now, just to talk about cataracts for a moment, I probably send out of the room, out of the office on a daily basis, as many cataract patients that are referred in for surgery as I actually schedule for surgery. Because a lot of times patients don't need the surgery quite yet. And there's no need to rush into those. But that's where the trust factor comes in. Or being able to spend time with a glaucoma patient. These are patients that are on eye drops 2, 3, 4 times a day for their whole life. How are they doing? Are they really using the therapy the way it's designed? Macular degeneration. My own mom is 90 years old. She's legally blind from macular degeneration. So it has hit home with me. So I take these things very seriously. I have from over the last 30 years. And so there are any number of ophthalmologists in the community or throughout New England. And I just want to set my practice as a honorable practice where we all try very hard to give the best of care.
But now when we talk about cataracts, I mean, that one hits home because all of a sudden things started going fuzzy, and during the day I couldn't even read signs. And I was told, well, you could go blind or you can deal with the cataracts. And I thought going blind wasn't a good thing. But at that point, I had to go to an ophthalmic surgeon because nobody else can actually perform the surgery. I mean, you can't go to an optometrist for surgery, correct?
That's correct, yes. Yes.
So you mentioned board certified.
Yeah.
So there's one knockout criteria I want to look at when I'm
That's a good
trying
point.
to decide.
Yes.
I mean, to me, unfortunately, the soccer field seems to be the great equalizer. Is you look around while you're watching your kids play soccer and say, who do you go to?
Yeah, that's a very good point.
You know,
Yes,
it's
yep.
just so funny when I hear so many patients have chosen their physicians because the other soccer moms or the other soccer dads
Exactly.
said, I went here.
Yep.
So board certified, experience. I mean, being from the center of the universe, I like people who are invested in our little town because I figure if you've been here 30 years, you're not going to leave real quick. You know, there's something to say about you've built your practice here, and you can't be too bad if you've survived for 30 years.
Well, thank you, but furthermore, I often, somewhat regretfully, end up doing consultations at Market Basket on Saturday mornings. When a patient, perhaps that has surgery 4 days earlier, comes over to me in the aisle and wants to ask a question. So if I have to duck around the corners because 3 out of 4 patients want to kill me, that's not a good reason
Well,
to
yeah,
stay there.
if they're throwing the tomatoes at you while you're in
exactly.
Market Basket, not a good thing.
But we have, I lead by example in my office, and we've just in the last, within the past year, we spent about $250,000 on a new microscope and a new called a phacoemulsifier, which is the main cataract machine. That machine is only about a month or 2 old in my office, and the one that it replaced was state of the art. So we really are very well respected in the industry. If I can just brag a little bit, the new phacoemulsifier, otherwise known as a phaco machine that I just purchased, has not been sold yet to Mass Eye and Ear. I will say that's not because they wanted to sell Glenn Goodman first. Before it was just easier to sell Glenn Goodman one as opposed to a dozen or so at the Mass Eye and Ear. But though that's the level, to be serious, that's the level that my surgical center is seen at by the ophthalmic representatives with whom I deal on a regular basis. We have a retina doctor in our practice who's been at the Mass Eye and Ear for decades, and without asking, and he has no reason to say this, but he's stated that the operating room that he uses at my facility is neater and cleaner and more hygienic than the one he uses at the Mass Eye and Ear. Now, and we take a great deal of pride in that.
And now, do other surgeons come to your center? I mean, is that
Yes,
open
yep.
to other surgeons?
Yes, that's a good question. I would say nationally, around the country, maybe at the most 40% of cataract surgeries are done in a hospital setting. The transition of the last decade has been to transition cataract surgery out of the general hospital. General hospitals are good for, like you said earlier, heart attacks, stroke, God forbid, serious things. Ophthalmic surgery and ophthalmology surgery procedures are usually not a high level of preference. The staff, as good as they are in general, are not attuned just to eye cases. So around the country, there's a significant transition. In Massachusetts, it's fairly conservative to doing cataract surgery outpatient in the surgical center. And so yes, there are other surgeons in the community who are using my facility because it's a separate entrance, a separate facility. There's no politics or I don't even see. Yes.
It's not like they're taking their patients and giving them to you.
Oh, absolutely not. No,
They're using your
That's
center.
exactly
well, it'd be
correct.
the same thing as going to Milford Hospital.
Oh, yes, exactly.
They're
right.
not turning over their patients to the hospital.
No, we just, and and again, thanks to Rachel, we provide, if the patients come from out of the community, we provide taxi service at our expense. So we try to really do it in a ooh-ah type of way. And to me, it may not be the most financially aggressive way to do things, but it sure is a lot of fun. And we really have a good time. Just to give you another example, if you've come across any of my patients in the area here, for the last 30 years, I shouldn't tell you this because other patients might pick up on this that haven't had surgery yet, but it's no big deal. I always give the patients an African violet or some type of nice plant with a photograph of me and the staff the next morning when they come back. So I've been doing that since day one, and I have no intention of stopping that. It's the little things that make this fun. Now, the surgery itself is very demanding. It's much more demanding in 2014 than it was in 1984. The techniques,
How so? I mean, what has really changed? Because from a patient perspective, okay, I read and I say, wait a minute, you're going to cut a 3mm slit in my eye? You're going to pulverize my lens with an ultrasound probe? I mean, all of these things did not endear me to the idea, but I go in, and the next thing I know, they're telling me it's done.
Mm-hmm.
So from a patient standpoint, I have to tell you, it seemed really easy to have cataracts done.
That's exactly right, and that's the way it should be. That's what we want. That's what we strive for the patient to say, quote, there was nothing to it. What goes on behind the scenes, so to speak, there's a lot to it. There's an infusion bottle with fluid going into the eye. There is this titanium pulverizer, if you will. There's a pedal at each of my feet, and there are monitors going, and I'm looking at so many things, and my assistant is handing me instruments. And so it is very challenging surgery. And the thing that's changed over the last 20 years is the transition to small incision, like you say, 2 or 3 millimeters, foldable lens implants. We now have bifocal lens implants. We have astigmatic lens implants.
Help me understand. When I did mine years ago, now, again, I have no clue. So a friend of mine was one of the head ophthalmic surgeons down at Walter Reed. He's my age. Old man I graduated, had ophthalmic surgeon for many decades. I called them, and I said, okay, I understand there's the plain old lenses, and then they got these fancy circular whatever it was that lets me see both far and close. back in the old days, they told me, well, if you get the progressive or whatever you call it, the graduated ones, you'll have okay vision throughout. Back then, they both told me, pick. So I picked lenses that all of a sudden my granny glasses went away and I could see perfectly short.
Yes.
And I have to wear my glasses for long.
Okay.
Has that changed now, or?
Well, somewhat it has, and ophthalmology is a very equipment intensive and technology intensive specialty. It's some of the things we do now would have been truly science fiction 10 years ago. So you're asking about lens implants. When the cataract comes out, we have to put an artificial lens in. In my days, years ago, we didn't have implants. People wore those thick glasses called Coke bottle glasses.
Yes.
Then there was a period of a decade or so where contact lenses were used after cataract surgery, again, before implants. But people in their 70s, 80s, and 90s had a hard time with contact lenses. So Dr. Fyodorov in Russia in the 70s, I guess, developed lens implants. And they were poo-pooed, they were criticized, and it was only the rogue ophthalmologist would do it, and it was going to damage the eyes and what have you. And it's been a lot of give and take over the years about the best way to, safety-wise, to approach this. But nonetheless, the use of intraocular lens implants is the standard of care these days. They can be made out of some form of plastic or silicone. They can be rigid. They can be foldable. Now, the most recent advent is what we call the multifocal. And that's in its infancy. It's in its development. I use them fairly often, but you have to be very selective in 2014, not what you may be able to have in your eye, and you would go, like you say, to the soccer game and say, well, Dr. Goodman put a multifocal and I can see far away and I can read the menu without glasses. Then you would say, well, why didn't he tell me I could have that? Well, because not every eye is amenable to that type of technology in 2014. Maybe we can both sit down here in 5 or 10 years and talk again, and we'll look back and say, boy, that was really strange back then. Now, if you don't get a multifocal implant, something's, the surgeon didn't give you the best of care. So this is what makes it very exciting for me, and we try to educate people. That's the fun of it. I have medical students come through. I've trained dozens and dozens of other doctors over the years, and we learn from each other, and it's a wonderful experience.
So now, if I asked you fundamentally, to a sociology major, what is a cataract and why do I get it? Was I drinking too much? Was I smoking too much? What did I do to get cataracts?
It's a good question. I can't give you a quick, simple answer. Of all the options you just threw at me, certainly smoking would be number one to stop for any, as you know.
Well, that's for any
reasons.
reason, yes.
But sometimes we see people in their 60s, heavy smokers with 80-year-old cataracts. But typically, we all tend to get them as an aging process. You can go through a list of issues that cause cataracts. Diabetes, diabetic patients more prone to cataracts. Anybody that's been on long-term steroid, cortisone use, whether it's a drop or pill or shot, cataracts.
Now, cataract is what, a glycogen deposit, or?
It's a hardening of the lens of the eye. The lens is in the middle of our eye, and I tell the patient, just like any lens in a microscope, telescope, or these TV cameras, it helps to focus. As we get older, the lens becomes more brittle microscopically, so it loses focusing ability, i.e. reading glasses in your 40s or 50s, and the cells of the lens don't get desquamated, they get compacted into the lens as the lens fibers continue to produce new cells throughout your lifetime. So there's only so much space there, and so it becomes more, we call it a nuclear cataract, it becomes more compacted, and ultimately yellow, clear becomes yellow, yellow becomes brown, and ultimately brown will become black if you let it go that long. So that the lens becomes discolored, can't focus, and you lose your light transmission through it.
And that's what happened, because I remember all of a sudden I thought my computer screens were not working as well, because there wasn't that vivid color. And then what I realized is during the day, I was horrible, because all of a sudden everything's contracting, and I'm trying to look through the center, which seems to be the highest density of deposit.
That's exactly correct.
So it felt like in my car, I have a steering wheel. And it's got a big plug in the middle that I can't see through, but my eyes adjust and look around. So at night, it seemed like my eye opened up that big.
That's
And
correct.
I could look around
That's
the center
exactly
plug.
correct. Yep.
But during the day, when everything constricts, I got too much of the area blocked out, and I couldn't see anything.
That's right. Less light getting in, and the light that was getting in was being blocked by the lens of the eye.
So at that point, really, I don't have a choice. I mean, being blind didn't seem like a good alternative.
That's correct. So we like to intervene at that sweet spot where the patient's symptomatic, but it hasn't become overripe, where it might be more tricky or more complicated to take it out. That's correct.
Now, I hear a lot about mapping the eye, using today's computer graphics.
Yes.
Especially in old fat men who are diabetic. They seem to like to take pictures.
Yes.
So they can compare and see if there's any of the, the tiny veins deteriorating. Is that become common?
Absolutely. Ophthalmology is a very visual science, so if we can see it, we want to photograph it. If we can photograph it, we want to photograph it over time. So you name the part of the eye, and we can take detailed photos, whether it be digital type of photographs or ultrasound. Those are two sciences that have developed very well in the field of ophthalmology. We also have laser scanners now. So we don't talk about scanning the eye or studying photographs of the eye. We can study any sub portion of the eye in great detail to a degree that was just unheard of 10 years ago. And the technology continues to change. More of it is becoming more three-dimensional. So you can map a diabetic retina and see it in 3D and map those changes as time goes by. The whole goal being not just to take nice, pretty pictures, but to be able to intervene therapeutically before there's sufficient vision loss that may not be reparable.
But doesn't that come with a pretty hefty technology price on the MD side?
Absolutely.
I mean, these toys can't be inexpensive.
That's what you hear about in the it's what the whole discussion that started in the last few years and will continue, is trying to find that right balance on the national level, on the federal level, between all the expenses required to run the country and how we're going to provide good health care for the citizens. But you're absolutely right.
We talked to a lot of the traditional primary care physicians. And it seems like you're getting back to the old days when we had the care. When we grew up in Milford, this is back in the ancient times when the dinosaurs ran, we had 4 physicians. And we all knew them, because you were either born by Dr. Chetty, Dr. Mastriani, you go through it. There's 4.
Dr. Pastorello.
You sit there and everybody knew.
Yeah, of course.
And they knew you.
Yes.
And you didn't have to try and put on airs because, they knew exactly. But there's a conflict now, because I've heard over and over that with Medicaid especially, because it seems like Medicaid is your lowest, Medicare is a little better, and then you hope for a lot of independent insurers, because the Medicaid patients don't even cover expenses for a lot of the traditional primary care health providers. How does that affect you? 'Cause I've heard people say, I'd love to take more and more Medicaid, but I have to limit myself or I can't feed my family.
Well, that's a good point. I'm probably not your typical physician in that regard. I was raised with a different outlook, and I've carried that through my life. I fortunately, we put the patient, and I don't mean to be altruistic here, but we put the patient first. I'll never refuse to see a patient. I always come in on.
Yeah, but if you go out of business.
I understand.
I mean, the killer is love the attitude. But if
Yes,
you took on all Medicaid and went
true.
out of business,
Yes,
then you can't help
That's
anybody.
exactly correct.
And you probably have a family like mine. I mean, very, how would one say, they're not giving in the fact that they want to eat every day. They want clothes. They're
true.
very
Yes,
selfish
yeah,
that
yeah.
way.
Well, there's certainly, I don't have an answer for that. I certainly understand it, and I certainly agree with it. I think that I think I bury my head in the sand over it because I can't control that, and I feel what I can control at my individual private level up on, 145 West Street is simply to give good care, and hopefully there'll be more payers than non-payers, and we've been successful, I guess.
But does the feds, when I look at CPT codes and things on that line, are they getting better or worse at covering, like when you say mapping an eye?
They are getting worse. There is no question. Now, and that's, I guess, what I could say to that is I enjoy my specialty as much today as I did 30 years ago. So I'm not probably the best person to answer that, but there's no question that we feel as physicians that it's being ramped down against us very much and ultimately hurting patient care. There's no way to justify what's happening here in terms of the fees payable to us. And nothing against plumbers or any of the tradespeople, but they make more money doing their thing than I do doing mine.
And they don't have to spend $500,000 outfitting
that's exactly right.
a suite.
You're absolutely right about that, and it's something that's going to be hopefully worked out, because what you'll find is, in my opinion, there's going to be fewer and fewer people wanting to go into private practice. I've had ads out to hire another doctor, and they have so much debt coming out of medical school, and they have such high expectations salary-wise that there's a major disconnect between what I can offer them and what they're looking for. And in general, they don't have, they're not old school like I am. I was a risk taker, I am a risk taker, and I enjoy what I do and I enjoy the practice. But the younger doctors are finding it hard to get through medical school, get through their training, and then to be able to afford a private practice. It's going to be very difficult.
Well, I remember when a friend of mine graduated Holy Cross.
Yes.
Went to med school, and all of a sudden he wanted to set up an eye care center, private practice. And we were close enough. He said, it's amazing how many years I've put in. Now, you've been able to work all that time, but I'm walking out of school owing $400,000, and now I need another, back then, $300,000.
Yep.
He says, I'm $750,000 in the hole, and I haven't earned $1 yet.
Mm-hmm.
So the gross revenue looked really good on paper. But when you had to service $750,000 worth of debt.
Yep, and that's before you buy a house.
That was just his business.
Yeah, exactly. Yep.
And again, that's before you have these offspring who want to be fed and clothed and everything else.
And you're absolutely right. You hit the nail on the head. I don't have an answer for it, and I hate to think that maybe I wouldn't have done this again if I was 30 years younger. I don't know.
Well, I know I had the discussion with my daughter, my youngest, when she was looking at, do I go into biotech business or the medical profession? And I said, sweetheart, you got to follow your passion. This is not a profession anymore that you go into because it's pure comfortable living, a very large salary without killing yourself. Everything you hear today is the MDs are working really hard for their money.
Exactly.
Not like 50 years ago when you
was
could work 3 days, 4 days a week.
Yeah.
But now, question always comes up on contacts.
Yes.
Somebody comes in, and I've never had contacts. I was always told I don't have the patience for them. But how do you decide? Do I get glasses? Do I get contacts? And then, of course, if I'm getting contacts, I mean, I saw this whole thing about these knockoffs you buy on the internet for 2 cents a piece that weren't quite sterile and weren't. But let's start with to contact or not to contact.
Well, it depends on the motivation. If it's a young teenager that wants to get out of his or her glasses, simple, rather straightforward prescription, go for it. And when you get older, in your 40s or 50s, if you want to avoid reading glasses or bifocals, then it becomes a little bit more tricky getting fit successfully. And then if you have, and you're in the cataract age in 70s and 80s, most people aren't interested in fiddling around with a contact lens. So they're certainly popular. They've been popular, of course, for generations. The technology keeps advancing, and with the advent of LASIK surgery, that's taken a cut into the contact lens portion of the population. People that previously were wearing or might have considered wearing contacts now are having laser surgery. But it's still got a certain niche there, and I still enjoy fitting them. I enjoy dealing with I enjoy treating the complications when they come up. and it's part of the whole package of treating patients. But again, we don't particularly care where patients buy their contacts, but they have to follow the hygiene rules. We don't want them, overwearing them or certainly buying stuff off
Well,
the
you
internet.
have now, my daughter got them
Yes.
to wear once a day,
Yes,
once a week,
sure.
Tuesdays, but not on
Yeah,
a
yeah,
Buddhist
yep.
holiday.
Yeah,
I mean,
yeah,
I can't
yeah.
figure out the rules.
It depends on the style, and you've just got to understand it. Of course, the most hygienic, theoretically, would be the daily disposables. You wear them, throw them out, wear them, throw them out. So there's no germs that can build up. Then you got your 2 weeks or your monthly disposables, your 3 months disposables, your annual ones that don't
Wait a minute,
dispose.
you'd have contacts in for a month?
No,
without taking
well,
them
you
out?
can. I mean, some of them are approved by the FDA for overnight use for that long. In my experience, my practice, we never allow, if you will, or
Advise, recommend.
over any overnight use. It just creates a high risk of infection.
You're still better off taking them out and washing
Absolutely,
them
yes,
every night.
yep, yep.
But now, if I buy my lenses through my eye care professional, I got a better, at least in my mind, I would expect that you're not going to sell me who contacts.
Well, that's absolutely right. Thank you for saying that, because what we do at my practice, and it's all I can speak to, is to deal with that issue so we always know what brand the patient's wearing and what strength and curvatures when they're being replaced. We just basically sell them at a minimal to no profit because we can computerize the delivery of the lenses. So if the patient's traveling somewhere or they lose one somewhere, we know immediately what they're wearing. Or when if they skip a few visits, they come back a year later, 2 years later, we know exactly what they were wearing when they lost it or what the problem is. We don't really care per se where patients buy them, but we realize at a higher level that there's a benefit to having everything centralized. So we try to.
Well, I mean, I can see why you don't care, because you're not making a lot of money on
Exactly.
it. So
Yeah.
But from a patient point of view, do I really save that much going on the internet?
Not with my practice, you don't.
Okay.
Because,
so realistically, if I'm paying a little tiny premium to know that you're watching out for me,
Yes. Yeah.
I can understand that. It's
yeah.
not double the price or anything.
Oh no. No.
Now, Halloween comes, and I see all the issues of kids
Yes.
who go on and buy, and I don't want to pick on the Far East, Chinese contacts that change your eyes to orange.
Oh yeah.
And then you find out the reason they're sold at novelty stores for 2 cents or $1 a piece is that's what they're worth, and they're not quite sterile.
Yeah.
I mean, I mean, that would scare the heck out of me to take something
absolutely.
that isn't at an FDA level
Of
and
course.
stick it. I mean, it's not like it's bad enough if I wear a ring and I turn
sure.
my
Yeah.
finger brown or
Yeah.
green, whatever.
Yeah.
But on a mucous membrane?
That's exactly right. So the reputable companies in the United States that make regular contacts make the novelty contacts.
Oh, they do.
And they're manufactured to the same high standards. So that's always fun, given.
So again,
yeah.
if I want to go crazy and
Yeah.
have blue, purple,
Sure.
I mean, Portuguese
Yeah.
with blue eyes,
Yeah.
that would be a new thing.
Yeah.
But I could go to my eye care
Absolutely.
and say,
You should do it
Dr.
that way.
Goodman,
Yeah.
I want blue eyes for
Right,
the week.
just for the night or the week or whatever. Absolutely. Or you want the bowling balls or whatever.
the
it is.
weird stuff.
Yeah,
but
yeah.
I don't have to try and, because when I saw these articles,
No,
there are kids who are permanently putting their
absolutely.
eyesight at risk.
Well, it's very sad. I mean, you have no idea. I mean, some of the infections that can be into contacts can persist for months and require corneal transplant surgery.
Oh, Lord.
Absolutely. Yes. Yep.
So besides the three that we've hit,
Yeah.
what would be the thing that keeps you the busiest on the other side, not the surgery?
On the medical side, I would say, well, of course, the three that we mentioned, and I'm fortunate to work with a good friend, Dr. Arnold Kroll, out of Mass Eye and Ear. He's a retinal specialist, so we share. He's right down the hall if I have a question about a retinal finding, a diabetic patient. Occasionally, throughout the year, once or twice a year, we find a melanoma of the eye that can save the patient's life by diagnosing that. Any number of inflammatory conditions related to rheumatoid arthritis. And I forgot to mention that a third of my training in my residency was in pediatric ophthalmology. So when you get the screaming 6-month-old with the nervous mom, nervous dad, either you, as the ophthalmologist, either you feel comfortable in that environment, which I do, or you don't. You start getting jittery, and all the anxiety in the room is building.
That would. I mean,
yeah.
My daughter is screaming, "Dad, fix this."
Mm-hmm.
You can do what you want to me. I don't care. But I can see my tension level is going to be up in the stratosphere.
It might be the parent's first baby, and the eye is turned in, or the pediatrician sent them over. Your child's got, so I enjoy that. I mean, that takes longer to do the exam. We don't make any more money or anything else. But if you can help the family understand, or if you need surgery or you need patching, it's a
First of all, calm me down, because that's going to help.
Yes, yeah.
Because the child is going to be looking at dad, and if dad is freaking out because the eye care specialist is making him nervous.
You got bullets sweating on your forehead, then the parents know maybe this ain't the right place, or maybe this guy doesn't know what he's doing. Now, one of my medical school classmates is a senior doctor at the Children's Hospital in ophthalmology. And so I have a good rapport with her. She's a very nice woman, and she's been there, and I'd be referring to her when need be. So that's one aspect that I enjoy. And just meeting patients over the years. I'm now dealing with. I'm getting old because I'm dealing with patients that I've operated on their grandparents. And it's been a blast.
The family history already.
Oh my God, yeah. I've operated on my high school principal. I've operated on teachers of mine, classmates of mine. It's who else can say that? I mean, it's just a wonderful experience, and I still enjoy it every day. It drives me. And just a little anecdote: when I was younger, I remember like it was yesterday. I was in the 10th grade at King Philip in Rentham. My mom and dad were having dinner, and what do you want to? We were just talking about what do you want to do, and she said, I think I want to be an ophthalmologist. So my mom, she's secretary and as normal as you could be, and she says, that's good. Why don't you want to be a real doctor?
Oh God.
And she meant it. She didn't mean it in a derogatory. She had no idea what an ophthalmologist was.
Understand it.
Exactly. But I had been raised to do what I like to do and be passionate about something. So I stood my ground, and I didn't become the plumber that they wanted. So
I remember before my father passed away, he always told me he was nervous. He kept saying, "Oh, Bab, someday they're going to find out you don't do anything. You fly all over the place. Yeah. You talk to people, have coffee. Yeah. What happens when they find out you have no skills, no trade?" Yeah. He says, "You'll be moving home with your family. I'll have to take care of you forever." There was no maliciousness.
He was looking out for your best interest. He was trying to be polite but supportive. Yeah.
In Portugal, they had their 4 years of school.
Yeah.
He was a magician with his hands. Put a tool in his hand, he can do anything.
Yeah.
So he never understood that, my strongest tool was a telephone. I said, "Dad, I can do plumbing. Just call Pintos. I can do electric. I call Brazza. Hey, Paul. Hey, Benny." He never could understand the logic.
Yeah. That was a different mindset, a different way. You make your own way in the world. You don't depend on somebody else to do those things.
So now, what do you think the biggest challenges are going to be as you go forward? I mean, reimbursement keeps getting worse.
Absolutely.
Technology demands keep increasing.
You're absolutely right. Yep.
Somewhere you get scared that the lines cross.
Well, people are already up in arms around the country over this. We don't know what the answer to this is. It's evolving, and I don't think that anybody knows. Look at what's happening just in the Boston area, the consolidation with partners buying hospitals. Everybody's starting to get nervous. Everybody wants to be one step ahead of the regulations and such. So we don't know. Something, you said it very well, something's going to come to a head. Might be later than sooner, but something has got to change because people want the best of care, but there's only a finite amount of money to pay for it.
Well, and I remember when we were living in France. My darling bride and I were there for 4 years, and I loved socialized medicine because we were on a private payer plan, and the physicians loved us. But the French had taken it to a point where it just wasn't worth putting an extra 6 years of your life into training to come out and make less than a plumber.
Yes.
Or make, not that a plumber was bad,
no,
but
I understand. I agree
you
with
come
that.
out, you go to work for somebody, you're working. And for us it was great because being on Blue Cross US, we got put to the head of the line because we were those people that you look at and say, oh, They're private payers. But I really worried because, I mean, don't take this the wrong way, but the guy who's got, or the gal who's got a very sharp knife to my eyes, I really want to know they're the brightest, the best.
I have the same feeling. I get paid for an operation, cataract surgery, the same as Joe Blow just out of his training one day. That's always been upsetting to me, that with my 30 years of experience, there's no differential in my, I guess the way to say that is the patients come to me because of that, perhaps, so maybe that is a benefit. But we're making 1/5 for what we did 30 years ago. Now, the cost of living hasn't gone down, 60%. It's maddening. It's absolutely maddening.
But you look at a lot of the people who are doing OBGYN.
Yes.
A lot of them just stopped
Absolutely.
and said, I'll stay with the gynecology because the obstetrics
is killing me.
I can't afford it.
Right, the malpractice coverage, absolutely. I just had a patient just today, a very well-known man from Milford, who was told that he needed cataract surgery, and I could have easily signed him up for surgery. I just don't have it in me. I sent him home. I said, you really don't need it yet. If you want it, we can do it. So you got to, in my opinion, you got to realize, leave that at the door in the morning, when and just deal with the patient as if it was your family member. But what you raise is a very good point. I mean, that's what we get discussions with at meetings and such. I was at the Hawaii Eye meeting 2 years ago, and we got invited out to dinner, for a drug company dinner. And I have a Hawaii medical license as well as my Mass license, and we still the reps got yelled at because Governor Patrick has since changed the law. In that 2 years ago, Massachusetts physicians could not be taken out to dinner.
See, that the whole Chopke law
Yeah.
drives me crazy, because if I could buy you as an MD for a pen or a block of sticky notes, wait a minute, there's something fundamentally wrong.
I agree with
here.
you. Yep. We use generics despite that they want us to use the brand name, but some of it makes sense, some of the rules and changes. Other stuff is just ridiculous.
Yeah, but see, there's where I feel more comfortable. You got a brandy new minted MD. Okay, experience of 1 year or 2, whatever it is. I kind of like the little white hair in 30 years of saying, for this kind of patient, I've run into 50 of you, even though I think I'm unique.
Exactly, yes, yep.
Yep.
And I agree with that 100%. It's like the only time me and Rachel go anywhere these days is once a year we go to the Hawaii Eye meeting. And I remember standing in line to get on the plane, and somebody said, I want to see a lot of gray hair on the captain. Well, it's the same thing in the operating room. But in that regard, I still have a responsibility. Despite 30 years, I don't know everything. I haven't seen everything. And so patients need to be able to have that trust that Dr. Goodman's going to treat them as best as he can, but if he's starting to get over his head, he's going to refer. And I think that's how I was brought up by the people that taught me. And so that's easy for me to play that role in the office. And I was, just on a personal level, I was out about 10 years ago with prostate cancer. And I was out of the office for a number of months. And people were, I was concerned about my health, and people were saying, well, aren't you worried about your practice? Yeah, I was worried about the practice. But suppose you're not going to be busy when you go back. And my answer was, I'll be as busy as I deserve to be. So, in other words, and I'm busy now as I was back then. So my point is that I enjoy what I do, and it's a lot of fun, and it's not all about me, it's about patient care. And these other social issues are terrible. And I hope that there will be a change in some fashion so that the good people continue to want to go into medical school, pay the price, it's extremely difficult, and still have a nice, happy career and happy family for the rest of their lives, I was, I was walking into the studio, I ran into Mr. Daigle from Joseph and Thomas Opticians. He is a gentleman, in my opinion, with a capital G. People like that are just wonderful, wonderful people, and there's a zillion of them in the Milford area that I've had the pleasure to meet. So it's a lot of fun, and that's what I try to carry forward in my practice, yes. Yeah.
Well, that's old school.
Yeah.
That's back to the original 4 physicians that you knew who they were, You know, and I always worry when you see a lot of, especially the primary cares, being told you have to turn a patient every 13.4 minutes.
Exactly, yep.
And you sit there and say, wait a minute, 13.4 minutes really doesn't give you a lot of time to kind of create that trust, you know?
Yeah, and what you hear a lot is that, I mean, and a lot I've heard of from several patients, that the primary care doctor says, what's on your mind today? And the patient might list 4 things. He says, well, pick 2 of them, and we're going to tackle them today. I mean,
I don't have the time to talk about all 4.
Yeah.
Amazing.
I don't know. It's weird. I was operated years ago on Mr. Sidney Smith, who was
God.
Yeah, and he was a nice man. He's, since, as you know, he's passed now, and he was just the nicest gentleman. And anyway, in his will, he donated because of me, several $100,000 to the hospital.
How wonderful!
It was amazing. It was incredible, you know. And so you do the right thing for the right reasons.
That always gets back what you're trying
it's amazing,
to teach your
you know?
kids, saying, do the right thing,
yeah.
and then somewhere up there,
but
somebody's keeping score.
It's been you know, wonderful. I never looked back. I was recruited here from BU, Boston University, where I was doing my training, and I haven't looked back. You know, it's a challenge every day. We have tough cases sometimes in the operating room, and I surround myself with very good people. So even somebody like me who's, you know, anyway, we worked hard, but we make it look easy because of the of the people, and the film crew picked up on that. They were so nice to come over and see us in action, and nobody was putting on airs or acting differently. It was just like, it was such a nice experience. You know?
It's good to see, as always, to our 6 loyal viewers, you're getting a flavor of old school. Somebody who cares about patients, but mixes it with the highest technology and quality levels available. So thank you for taking care of our families, and as always, may God bless, and may you have a better day tomorrow, and see sharper and more vividly for the future. Good night, all. Thank you.
Thank you.